All right, let's kick this off. Our mission today is pretty laser focused and honestly incredibly high stakes. We are basically building the ultimate hyper efficient cram guide, really for someone in that final intense phase of USMLE Step 1 prep. And we're not just summarizing here. We're trying to create the cognitive architecture for success, going straight for those highest yield integrated concepts that really separate, the test takers from future clinicians.
It's absolutely right. Yeah, for anyone aiming for peak performance, this deep dive is all about maximizing, let's call it conversion efficiency. Turning those review hours into actual guaranteed points on the board. And the USMLE blueprint itself, it's not exactly subtle about this. It is an integrated exam, sure, organized by organ system.
Right, systems-based.
But look, 2 domains just dominate the score weight. You absolutely have to know them.
And those are the big ones, the giants. Pathology, making up just a staggering 45 to 55% of the entire test.
Almost half, yeah.
And then the integrated reproductive and endocrine systems. Together, they're another critical, 12 to 16%?
Exactly. You must secure those 2 areas. There's no way around it for a top score.
Okay. Look, before we dive in, just a quick personal note from both of us.
Yes.
Michelle, we love you. We know you are going to make an absolutely amazing physician, a compassionate pediatrician, a really thoughtful psychologist, a true healer. We see your incredible dedication, especially now in these final weeks.
We really do. Now let's go get those points.
Okay.
So we're prioritizing pathophysiology, and specifically understanding how basic science principles, molecular biology, genetics, normal physiology, how they actually explain the disease.
Right. It's not just definitions.
Not at all. The exam doesn't just ask you to, recognize a definition. The vast majority of the test requires you to interpret graphic data or apply foundational science principles and solve complex problems using that integrated reasoning, always in the context of disease.
So our goal, then, is really to help you move beyond just rote memorization.
Exactly.
It's about understanding how a normal pathway or a protein or maybe an immune response gets broken.
Yes.
And crucially, how that failure shows up in a patient vignette.
That's the key linkage.
So what we're going to do is construct this, let's call it a brutal, high-yield cram packet. We'll use rapid-fire short answers, introduce some really unforgettable memory techniques these mnemonics are, like scientifically designed for emotional recall, which is fascinating.
They really stick.
And then we'll finish with a simulated oral exam drill. 25 integrated USMLE vignettes. Let's really make these critical concepts stick. Okay, let's start with the mindset. Because cramming at this final stage, it really is about studying smart, not just hard, right?
Absolutely. The hours are long, but the structure is key.
And the suggested daily schedule we looked at, it's intense, no doubt, but it's structured for maximum cognitive load and, importantly, retention. It kind of respects the fact that you're shifting gears, moving from just acquiring info to really retaining and applying it.
Yeah, the minimum recommended is that 8 to 12-hour structured day. And how you allocate that time is absolutely critical. It's basically a 4-4-2 split that seems to work best.
Okay, break that down.
So 4 hours dedicated to reviewing core concepts like first aid, pathoma, your own notes, whatever your core resources.
Right.
Then 4 hours, and this is non-negotiable, spent purely on practice questions, UWorld, AMBOSS, whichever bank you're using. And then the final 2 hours are specifically focused on fixing those weak areas you identified through the questions, using active recall tools like Anki or just self-testing.
I like that the ratio is almost 1-to-1 content review versus application with question banks.
It has to be at this stage.
Because at this point, practice questions aren't just for assessment, are they? They're actually the primary learning resource.
Yeah.
Every single question is like a mini lecture.
Exactly. And within that structure, that rigorous schedule, we hit what we like to call the pathology golden ticket strategy.
Okay, I like the sound of that.
It's the core principle, really. You must secure your knowledge of normal function first. Then you layer on the disease.
Ah, okay. So know the normal before you know the broken.
Precisely. If you know the normal feedback loop of the HPA axis, for instance, you can immediately predict why exogenous steroids cause adrenal atrophy. Makes perfect sense then.
Right.
Or if you understand normal, smooth muscle cell function in a vessel wall, you instantly grasp why its proliferation causes intimal thickening and atherosclerosis.
So the test isn't just asking what is normal function, it's asking what's the functional change, the delta, when that normal process gets disrupted.
Precisely. And this strategy, it's validated by the exam blueprint itself. Applying foundational science concepts drives a huge chunk of the exam, something like 60 to 70% of the actual questions.
Wow, that much.
Yes. So if you can confidently explain the why, like why an immune complex deposits in this layer of the glomerulus versus that one, you unlock multiple potential questions. You're turning specific facts into powerful, flexible knowledge.
Okay, so making that why automatic, especially under pressure, is key. And we saw this really brilliant kind of advanced study hack inspired by AI research, apparently, the MED-RLVR concept.
And RLVR, yeah. The reinforcement learning mindset.
It sounds complicated, but the application seems beautifully simple, especially for a high-performing student getting ready for this final hurdle.
It is. It's essentially training your brain to generate a diagnosis, not just recognize one. It shifts you from passive information intake to a really active, predictive, cognitive process.
How does it work in practice?
Okay, so after reading a clinical vignette, you pause, resist that immediate urge to just click an answer.
Right, the trigger finger.
Exactly. First, you actively predict the answer. Then, and this is crucial, you explain your reasoning out loud. You have to connect every single clinical clue, patient age, symptoms, lab values, to the underlying basic science principle.
Why out loud? Why is the verbal part so important? Most people just think it through.
Thinking is internal, and often it's a bit fuzzy, Verbalizing forces you to structure the causal chain clearly, like, okay, because the patient has A and B, that must mean enzyme X is deficient, which causes precursor Y to build up, leading to symptom Z.
It forces clarity.
Exactly. Then you get immediate feedback from the question bank. And crucially, you refine your strategy after every single error. This process trains the brain's reward system to quickly spot and correct diagnostic pitfalls. It basically simulates the high-stakes thinking you'll use as a doctor.
So it turns passive reading into this kind of high-octane diagnostic simulation. I love it.
It really works.
Okay, so this disciplined approach, the 4-4-2 schedule, locking down normal function first, and using this MED-RLVR mindset that's the foundation. Now that we've got that mindset of active prediction and refinement, let's immediately put that cognitive muscle to work with our rapid-fire pathology drill.
Let's do it. All right, time to apply that golden ticket strategy. We're going to hammer the highest yield pathology concepts across the major systems. Focus on the mechanism, the histology, the classic buzzwords we need, the deep understanding behind the clinical finding. Hashtag A, reproductive and endocrine systems, pathology integration.
Okay, starting strong. Highest weighted systems. Prolactinoma causing amenorrhea, we know the symptom, but what's the precise hypothalamic pituitary mechanism they're testing?
Okay, the precise mechanism. It's hyperprolactinemia inhibiting the pulsatile release of gonadotropin-releasing hormone, GnRH, from the hypothalamus.
Pulsatile is key.
Absolutely. Low GnRH pulses mean decreased downstream LH and FSH from the pituitary. That leads directly to an ovulation, and bam, amenorrhea. The whole feedback loop gets shut down right at the top.
Got it. Shut down at the top. Okay, next. Type I endometrial carcinoma. Postmenopausal woman, bleeding. What's the single biggest risk factor and, importantly, the molecular link?
The number one risk factor is prolonged, unopposed estrogen exposure. Think obesity, chronic anovulation like PCOS, nulliparity, estrogen therapy without progesterone.
Right, anything that keeps building the lining up.
Exactly. Mechanistically, that sustained proliferative signal without the periodic shedding leads to endometrial hyperplasia, which can progress to carcinoma. And this pathway is strongly associated with a loss of function mutation in the PTN tumor suppressor gene.
PTN. And what does PTN normally do?
PTEN normally inhibits the 3K-AKT-mTOR pathway, which basically slows down cell growth. So lose PTN and you get uncontrolled proliferation.
Makes sense. Moving to the adrenal gland. Pheochromocytoma, young patient, episodic hypertension, anxiety, maybe elevated urinary VMA. We need the cell origin, the classic histology pattern, and its common genetic association.
Okay, origin, adrenal medulla, specifically the chromaffin cells. These are derived from the neural crest.
Neural crest, right.
Histology. You're looking for polygonal or chromaffin cells arranged in these distinctive dense nests or clusters. Pathologists call them Zellballen.
Zellballen. Got to know that term.
Absolutely. It's highly characteristic, confirms the neuroendocrine lineage. And don't forget its strong association with MEN2 syndromes, multiple endocrine neoplasia type 2, tests that genetics link.
Right. MEN2A and 2B. Okay, Graves' disease. We know the classic symptoms, heat intolerance, weight loss, maybe the bulging eyes. But what's the core autoimmune process being tested?
The core process is the production of TSH receptor-stimulating antibodies. They're IgG immunoglobulins.
Stimulating, not blocking.
Critically stimulating. These antibodies act like agonists. They constantly activate the TSH receptor, completely bypassing the normal pituitary negative feedback. So the gland just keeps pumping out thyroid hormone uncontrollably. Hyperthyroidism.
Got it. Okay, congenital adrenal hyperplasia, CAH, specifically the most common form, enzyme deficiency, and the crucial lab elevation that clinches it.
It's 21-hydroxylase deficiency, by far the most common.
21-hydroxylase.
Right. Since this enzyme is needed to make cortisol and aldosterone, blocking it shunts all those steroid precursors over towards making adrenal androgens instead.
Hence the virilization sometimes.
Exactly. And the key lab finding, the one that really nails the diagnosis, is a significantly high serum level of 17-hydroxyprogesterone. That's the precursor that builds up right before the 21-hydroxylase block.
17-hydroxyprogesterone. Okay. Finally, linking reproduction to structural basic science. Primary ciliary dyskinesia, or Cardigan syndrome, what's a fundamental defect, and the dual presentation linking male reproduction and lungs.
Okay, the underlying pathology is a defect in the dynein arm structure. Dynein arms are essential motors for cilia and flagella motility.
Dynein arms.
Right. So since cilia line the respiratory tract and flagella drive sperm, the classic dual presentation is chronic respiratory infections, think sinusitis, bronchiectasis, and male infertility due to non-motile sperm. It's typically inherited autosomal recessive.
Perfect link between structure and function. #TAGB cardiovascular system. Pathology and mechanisms. Okay, shifting gears to the heart and vessels. Myocardial infarction, MI. We know unstable plaque rupture is the immediate trigger, but let's go deeper. What's the fundamental cellular driver of the underlying intimal thickening and atherosclerosis before the rupture?
Okay, yeah, the initial lesion starts with endothelial injury and dysfunction, then macrophages come in, become foam cells.
Right, the fatty streak.
But the actual thickening that narrows the lumen, the bulk of the plaque, that's fundamentally caused by smooth muscle cell migration and proliferation. They move from the medial layer into the intima and just start dividing.
Smooth muscle cells?
Mm-hmm.
And the unstable part, the bit that ruptures.
Right, the unstable plaque specifically is a fibrofatty plaque that has a thin fibrous cap covering a large necrotic lipid core. That thin cap is vulnerable.
Got it. Hypertrophic cardiomyopathy, HCM, the feared cause of sudden death in young athletes. Genetic defect, and more importantly, the precise mechanism of death.
Genetically, it's typically an autosomal dominant mutation in genes encoding sarcomeric proteins. Most commonly, the beta-myosin heavy chain or myosin-binding protein C.
Sarcomeric protein.
Exactly. Now, while the hypertrophy itself can cause dynamic left ventricular outflow tract obstruction.
Which can cause syncope.
Right, but the most common cause of sudden death isn't the obstruction itself. It's usually a fatal ventricular arrhythmia. This is often secondary to the myocardial disarray and fibrosis caused by the mutation. That cellular chaos creates electrical instability.
So arrhythmia, not just blockage. Crucial distinction.
Very crucial for the exam.
Okay, infective endocarditis. Specifically, the subacute kind, maybe after a routine dental procedure. Which bug is the high-yield answer, and why is it called subacute?
Viridans group Streptococci. Things like Strep mutans or Strep sanguinis.
Monomal flora.
Exactly. They typically cause disease on already damaged heart valves, and they're categorized as subacute because they're lower virulence organisms. They cause a slower, less destructive infection compared to, say, the aggressive acute infections you see with Staph aureus on normal valves.
Lower virulence, lower course. Okay.
Yeah.
Aortic dissection, often linked to long-standing, uncontrolled hypertension. The tear happens in which structural layer, and what's the underlying tissue pathology there?
So the initial tear is usually in the intima, but the dissection itself is when blood tracks into the media layer, creating a false lumen.
Into the media.
Yes, and the underlying tissue pathology in the media, often accelerated by that chronic high pressure, is fragmentation of elastic fibers and something called cystic medial degeneration or necrosis.
Cystic medial degeneration.
Right. It basically means the structural scaffolding of the aorta is breaking down, dissolving almost. Makes it brittle, weak, and prone to catastrophic tearing or separation under the high shear stress of blood flow. #TAG, respiratory and renal urinary systems, integrated pathology.
Okay, integrating systems now, kidney and lung, renal cell carcinoma, RCC, and its perineoplastic syndromes. Patient has RCC, and labs show polycythemia, high red cell count.
Yeah.
What's the mechanism they're testing?
Okay, the tumor itself, which arises from the proximal renal tubule cells often associated with VHL gene loss,
VHL, right.
can ectopically produce erythropoietin, EPO, It acts like an unintended hormone factory.
I mean, making EPO it shouldn't be making.
Exactly. This excess EPO drives red blood cell production way up in the bone marrow, leading to secondary polycythemia and that elevated hematocrit. Classic paraneoplastic effect.
Got it. Acute tubular necrosis, ATN, often from ischemia like shock or nephrotoxins. Which specific parts of the nephron are most vulnerable, metabolically speaking? And what's the classic finding in the urine?
The most susceptible segments are the proximal tubule and the thick ascending limb of the loop of Henle.
PT and TL.
Yep. Because they're the most metabolically active, they need the most oxygen. When they die due to ischemia or toxins, the cells slough off into the tubular lumen and form those pathognomonic muddy brown casts you see on urinalysis.
Muddy brown casts. Key finding for ATN.
Absolutely screams ATN.
Okay, rapidly progressive glomerulonephritis, RPGN, that's a renal emergency, characterized by crescents in Bowman space. How do we tell Goodpasture syndrome apart from post-streptococcal GN, PSGN, using immunofluorescence? What's the key pattern difference?
This is a classic exam differentiation. Goodpasture syndrome, which is anti-GBM disease, shows a linear deposition of IgG along the glomerular basement membrane. It's smooth, like a line, because the antibodies are binding uniformly to the GBM itself.
Linear for Goodpasture.
Right. PSGN, on the other hand, is an immune complex-mediated disease, so it shows a granular deposition pattern on IF, often described as lumpy bumpy or starry sky. These correspond to those immune complex humps that deposit subepithelially.
Granular for PSGN complexes. The pattern tells the whole story.
Precisely. Tells you the mechanism of injury.
Okay, finally, COPD, specifically emphysema in a long-term smoker. What's the major physiologic consequence? How does the lung function change? And which type of emphysema is typical in smokers?
Physiologically, the core problem is the destruction of the alveolar walls. This leads to a massive loss of elastic recoil in the lung tissue.
Loss to elasticity.
Right. This causes air trapping, especially during exhalation. The result is a significantly increased residual volume and often total lung capacity, too. Lungs get hyperinflated.
Air trapping, high RV.
And the classic type associated with smoking is centriacinar emphysema. It primarily affects the central part of the respiratory unit, the respiratory bronchioles, and tends to be worse in the upper lobes.
Centriacinar upper lobes for smokers. Got it. Hashtag tag D, musculoskeletal, skin, and subcutaneous tissue. Buzzwords. All right, quick hits now. Differentiating the two big pediatric bone sarcomas, Ewing sarcoma versus osteosarcoma. Location and X-ray are key, but beyond that, what's the crucial molecular hallmark of Ewing's?
Okay, quick diff. Osteosarcoma is usually in the metaphysis, near the growth plate, often shows that sunburst pattern or Codman triangle on X-ray. Ewing sarcoma is typically in the diaphysis, the shaft of long bones, shows the classic onion skin periosteel reaction.
Onion skin layering.
Right. And its molecular marker, the defining feature, is the T1122 chromosomal translocation. This creates the EWS-FLI1 fusion protein. It's a small, round, blue cell tumor.
T1122 EWS-FLI1 for Ewing's. Okay. Gout classic joint, crystal shape, and the key optical property.
Classic joint is the first metatarsophalangeal joint, the big toe.
Podagra.
The crystal is needle-shaped monosodium urate, and the key optical property under polarized light is negative birefringence.
Negative birefringence. What does that look like?
It means when the crystal is aligned parallel to the slow ray of the light compensator, it appears yellow. Perpendicular, it's blue, but parallel yellow is the key for gout.
Parallel yellow negative. Got it. Duchenne muscular dystrophy. Specific genetic defect, inheritance pattern, and the classic physical sign that links pathology to weakness.
It's an X-linked recessive deletion of the dystrophin gene.
Dystrophin gene deletion, X-linked.
Right. Dystrophin is this huge, critical structural protein that anchors the muscle cell's cytoskeleton to the extracellular matrix. Without it, muscle fibers become unstable, easily damaged, leading to weakness and necrosis. The classic sign is the Gower sign or maneuver.
Gower sign.
Yeah, where the child has to use their hands to kind of walk up their own legs to stand up because of that profound proximal muscle weakness.
Right, pushing off their legs. Okay, finally, the two big autoimmune blistering diseases, pemphigus vulgaris versus bullous pemphigoid. Focus on the antigen target and the precise level of the skin split.
Okay. Pemphigus vulgaris, PV, targets desmosomes, specifically antibodies against desmoglein 3 and sometimes desmoglein 1. Desmosomes hold keratinocytes together, so you get a split within the epidermis. It's intraepidermal, specifically suprabasal acantholysis, leads to flaccid blisters that rupture easily, positive Nikolsky sign.
PV, intraepidermal, antidesmoglein, flaccid.
Exactly. Bullous pemphigoid, BP, targets proteins in the hemidesmosome, which anchors the basal keratinocytes to the basement membrane, specifically BP180 and BP230. So the split occurs below the epidermis. It's subepidermal.
BP is subepidermal antihemidesmosome. Tense.
Right. This leads to large, tense bullae because the roof of the blister is the entire epidermis, so it's stronger. Nikolsky sign is usually negative.
Perfect distinction. And for melanoma, the most dangerous skin cancer,
Yeah.
what single factor is the absolute most important determinant of prognosis and staging?
Depth of invasion, formerly known as the Breslow thickness.
Breslow thickness.
Yes, it's measured vertically from the granular layer of the epidermis down to the deepest identifiable infiltrating melanoma cell in the dermis or subcutaneous tissue. It directly correlates with the risk of metastasis. Everything else is secondary to depth.
Depth is king for melanoma.
Okay, we've hammered the facts, the mechanisms, the histology, but let's be real, a lot of that is dense, it's dry, under exam stress, poof, it can just evaporate.
Totally. The recall failure under pressure is real.
Exactly. So this is where we introduce the art of mnemonic storytelling and sort of emotional anchoring. We need to make the information sticky by engaging parts of the brain that are normally used for narrative, emotions, spatial memory.
I find this approach really revolutionary compared to just random acronyms. Instead of some lifeless string of letters, we're creating a vivid image or an emotion, maybe even a joke that's so absurd or memorable. The fact comes bundled with it.
That's the goal. Your brain is naturally programmed to remember stories and strong images much better than abstract facts. Let's look at some examples, connecting these dense pathology facts to, like you said, emotional themes. Hashtag A, the love and romance mnemonics for biochemistry and endocrine.
Okay, using themes of relationships, secrets.
Mm.
How does that work for genetics, like autosomal recessive inheritance?
Right, so we call autosomal recessive the secret love affair.
Okay.
Why? Because for the condition, let's take Tay-Sachs with its hexaminidase. A deficiency to actually show up, to manifest, you need two hidden halves. Right? Two recessive allele to make a whole disorder.
Ah, two secrets coming together.
Exactly. Both parents are secret carriers, totally healthy themselves. Only when those two secrets meet in the offspring does the disorder become apparent. That little narrative of two hidden people creating a whole outcome instantly reinforces the concept that you need two copies of the faulty gene.
That actually makes the two-copy requirement feel really intuitive.
Oh.
Okay, let's try a vitamin deficiency. Niacin B3 causing pellagra, the 3Ds, dermatitis, diarrhea, dementia.
Okay, niacin B3 is the nice boy 3D of vitamins.
Nice boy 3D.
Yeah. He's essential for the body's whole energy love life, helping all those crucial NAD and NADP redox reactions find their perfect metabolic partners.
Okay, the energy matchmaker.
Pretty much. So if you don't have enough of the nice boy, your body's energy metabolism is severely lacking, and you get the 3Ds, dermatitis, diarrhea, dementia. The 3D part makes it an easy hook linked to B3.
Nice boy 3D for niacin B3. I like it. And for something more dramatic like aortic dissection, that sudden catastrophic event, we anchored it with dividing love.
Yeah, think of it as the sudden, devastating breakup of the vessel wall structure. The layers are literally torn apart.
Okay.
Patients often report the sudden, severe tearing chest pain, like their heart is being ripped in two. And this division often manifests physically, too, with an uneven pulse or a significant blood pressure discrepancy between the arms.
The unequal BPs.
Right. So linking the physical tearing and division to the emotional trauma of a sudden, brutal separation helps lock in the catastrophic nature of the dissection. Dividing love, tearing pain, and uneven pulse.
That's powerful. Hashtag B. The faith in healing acrostics for microbiology and metabolism.
Okay, shifting themes slightly. Connecting facts to ideas of diligence, protection, trust, which can be useful for things like biochemistry and micro. Let's start with G6PD deficiency. That enzyme is crucial for protecting red blood cells from oxidative stress.
Right, keeps them safe.
So we use the acrostic GRACE for G6PD. It emphasizes that protective role the enzyme normally plays.
GRACE. What does it stand for?
Okay. Glutathione regeneration is impaired. That's the enzyme's job. RBCs are defenseless against oxidative stress. Acute hemolysis gets triggered by things like fava beans, sulfa drugs, infections. And the cytoplasm shows characteristic Heinz bodies and bite cells after the spleen gets involved. Essentially, the cell loses its protective grace.
Grace for G6PD.
Nice. Okay, maple syrup urine disease, MSUD. Tough metabolic disorder, serious consequences if not managed.
Yeah, so for MSUD, we use PRAY. This emphasizes the diligence and, frankly, the hope required for management.
PREY.
Poor feeding and vomiting are common early signs. It requires lifelong dietary restriction of branched-chain amino acids leucine, isoleucine, valine. The deficient enzyme is alpha-keto acid dehydrogenase complex, and it yields that characteristic sweet, burnt sugar or maple syrup odor in the urine and sweat due to the buildup of those branched-chain alpha-keto acids.
Pray for MSUD management. Makes sense. And for a really high-yield bug, Clostridioides difficile, C. diff.
Yes, C. diff. We use TRUST for this one. It reminds you of the key points for diagnosis, prevention, and treatment. TRUST C. diff. Go for it.
Toxins A, enterotoxin, and B, cytotoxin, cause the watery diarrhea and pseudomembranous colitis. It typically results from antibiotic use disrupting normal gut flora, especially clindamycin, fluoroquinolones, broad-spectrum penicillin cephalosporins. Critically, you must use soap and water for hand hygiene because the spores resist alcohol-based hand
Yes, of
gel.
course. Right, gotta wash them up.
Exactly. And you treat it typically with oral vancomycin or fidaxomicin. So TRUST covers the bases. Hashtag C, the high-yield acronym mnemonics, child-friendly hooks.
Okay, these next ones use kind of delightfully absurd imagery. Cognitive science loves this stuff, right? Because it leverages spatial and visual memory so well. Let's start with Ewing sarcoma again, that T1122 translocation creating the EWS-FLI1 fusion protein.
Right. So for Ewing's, the phrase is, the UWS-Fly1 bandit hides in the onion bone castle.
Okay, UWS-Fly1 bandit.
Yeah, UWS-FI1 sounds like UWS-Fly1. This instantly links the fusion protein, the bandit, to the characteristic onion skin periosteel reaction, the onion bone castle where he hides.
EWS-FLI1 in the onion bone castle.
Exactly. The imagery is so specific and, frankly, ridiculous, you won't forget the three key elements. Fusion protein, onion skin, bone tumor when you see that X-ray and histology.
That's brilliant. Okay, vascular Ehlers-Danlos syndrome. The dangerous type 3 collagen defect, gene COL3A1, leading to vessel rupture risk.
For this one, Halo 3 is a tea bag that rips too easily, especially vessels.
The Halo-3 T-bag.
Yeah. Type 3 collagen, COL3A1 gene, is normally found in flexible, distensible tissues like blood vessels, skin, uterus, bowels. Linking COL3 to a fragile tea bag that rips too easily helps you recall the serious risk of spontaneous arterial rupture, bowel perforation, uterine rupture associated with this specific collagen defect.
HEOL3 T-bag rips too easily. Got it. And finally, pemphigus vulgaris, those flaccid intradermal blisters caused by autoantibodies against desmoglane.
Okay, this one's fun. The vulgar blister snake ate the desmo chain inside the skin.
Whoa. Okay, break that down.
Vulgar links to pemphigus vulgaris. The blister snake represents the flaccid, easily ruptured bulla. It ate the desmo chain, that's your autoantibody target, the desmosomes, desmoglane 3. And where did it happen? Inside the skin, reminding you it's an intraepidermal split.
Vulgar snake ate the desmo chain inside. That's memorable.
The absurdity ensures those key facts, name, target, location, blister type, are locked together even under duress.
All right. We've armed you with the blueprint, the deep mechanisms, those sticky memory hooks. Now for the real test application. We're going to run through a simulated oral exam, hitting vignettes that demand immediate integration of basic science and pathophysiology. Remember, the goal isn't just spitting out the answer, but explaining the functional deficit you're diagnosing.
Exactly. We're training that clinical reasoning under pressure. For each question, try to identify the core USMLE pattern being tested, linking clinical findings back to the underlying science. Ready?
Let's do it. Hashtag pathology of endocrine reproductive. Focus on disrupted feedback. Question 1. A 32-year-old woman presents with several months of amenorrhea and some galactorrhea. Labs show a prolactin level of 150 ng/ml, and an MRI confirms an enhancing pituitary mass. Which of the following best explains her amenorrhea from a hormonal perspective?
Okay, the key here is central feedback inhibition. The high prolactin level directly inhibits the pulsatile release of GnRH from the hypothalamus.
Right, back to GnRH pulses.
Exactly. Suppressed GnRH leads to reduced LH and FSH secretion by the pituitary, which ultimately causes an ovulation and therefore amenorrhea. It's the high prolactin level causing the hormonal imbalance, not necessarily the physical mass effect of the tumor itself, although that can cause other issues like headaches or vision changes.
Got it. Question 2. A patient presents with classic signs of Cushing syndrome, proximal muscle weakness, central obesity, maybe some striae. Labs show elevated ACTH levels. However, their cortisol secretion remains unsuppressed even after a high-dose dexamethasone suppression test. What's the most likely underlying cause, and what's the mechanism of this resistance to suppression?
This pattern points strongly towards ectopic ACTH secretion. Most commonly, this originates from a small cell lung cancer, SCLC, but other neuroendocrine tumors can do it too.
Ectopic ACTH, and why doesn't the dexamethasone suppress it?
The basic science principle is that ectopic hormone secretion operates completely outside the normal hypothalamic pituitary adrenal HPA axis regulation. The tumor cells are autonomously pumping out ACTH. They generally lack the necessary glucocorticoid receptors to sense and respond to the negative feedback signal provided by the high-dose dexamethasone. The pituitary corticotrophs would be suppressed, but the tumor doesn't care.
Makes sense. Autonomous production. Question 3. A young woman, maybe early 20s, presents with irregular periods, obesity, and hirsutism. Ultrasound shows polycystic ovaries. Labs show an elevated LH to FSH ratio, maybe around 3.1, and high levels of circulating androgens. Explain the core pathophysiology linking her likely metabolic status to her ovarian dysfunction in polycystic ovary syndrome, PCOS.
The core link in many PCOS patients is underlying insulin resistance.
Insulin resistance is key.
Yes. The resulting hyperinsulinemia has a couple of major effects. First, it directly stimulates the ovarian Theca cells to overproduce androgens. Second, insulin decreases the liver's production of sex hormone-binding globulin, or SHBG.
Less SHBG mean?
Less SHBG means more of the androgens that are produced are circulating in their free, biologically active form. This combined androgen excess disrupts normal follicular development and maturation, leading to arrested follicles, the 6, and chronic anovulation, hence the irregular periods and infertility.
Insulin resistance, high androgens, anovulation. Got it. Question 4. A 45-year-old woman has long-standing fatigue, weight gain, cold intolerance. She's diagnosed with Hashimoto thyroiditis based on high anti-TPO antibodies. A biopsy of her thyroid, if done, would typically show extensive lymphoid aggregates, often with germinal center formation. What serious malignancy is she at increased risk for later in life due to this specific chronic inflammatory process?
Hashimoto thyroiditis, yes. That chronic severe lymphocytic inflammation and especially the formation of those organized lymphoid aggregates with germinal centers significantly increases her lifelong risk for developing a specific type of lymphoma within the thyroid gland itself. It's called a mucosa-associated lymphoid tissue, MLT lymphoma, which is a type of non-Hodgkin B-cell lymphoma.
Multiple lymphoma risk with Hashimoto's. Okay, hashtag tag cardiovascular integration, genetics injury. Question 5. A 19-year-old male college basketball player suffers exertional syncope during practice. An echocardiogram reveals massive asymmetric septal hypertrophy. His family history is positive for sudden cardiac death in a cousin. What's the typical genetic mechanism underlying this condition, and what is the most common immediate cause of sudden death in these patients?
Okay, the condition is hypertrophic cardiomyopathy, HCM. It's typically caused by an autosomal dominant mutation in genes encoding sarcomeric proteins, the building blocks of the heart muscle. Beta-myosin heavy chain and myosin-binding protein C are the most common culprits.
Autosomal dominant sarcomeric proteins.
Yeah.
And the sudden death.
While the asymmetric septal hypertrophy can cause dynamic left ventricular outflow tract obstruction, leading to symptoms like syncope, the actual immediate mechanism of sudden death is almost always a fatal ventricular arrhythmia like ventricular tachycardia or fibrillation.
Ah, arrhythmia again, not just obstruction.
Exactly. The underlying myocardial fibrosis and cellular disarray caused by the genetic mutation create an unstable electrical substrate, making lethal arrhythmias much more likely, especially during exertion.
Question 6. A 60-year-old man with poorly controlled hypertension presents to the ED with sudden onset severe tearing chest pain radiating straight through to his back. A CT angiogram confirms an ascending aortic dissection. What is the fundamental underlying histologic change within the aortic wall's medial layer that predisposed him to this catastrophic event?
The key underlying pathology, often accelerated by that chronic pounding hypertension, is fragmentation of the elastic fibers within the media, combined with cystic medial degeneration, sometimes called mucoid degeneration.
Elastic fiber fragmentation and cystic medial degeneration.
Right. Essentially, the structural integrity, the scaffolding of the aortic media weakens and degenerates. It becomes less resilient, more brittle, making it highly susceptible to developing an intimal tear and then allowing blood to track under pressure through these weakened areas, dissecting the layers apart.
Question 7. A 60-year-old male is hospitalized following a large myocardial infarction. Several days later, around day 4 or 5, he suddenly collapses with signs of cardiac tamponade. If the dreaded complication of free wall rupture occurred, which specific cell type would be dominating the myocardial histology at that particular time point, making the infarcted wall weakest and most prone to rupture?
Macrophages. Absolutely macrophage.
Macrophages. Okay, why?
Days 3 to 7 post-MI represent the peak of the inflammatory response. This phase is characterized by massive infiltration of macrophages into the necrotic zone. Their job is to phagocytose, to clean up all the dead myocardial debris.
Cleaning up the mess.
Right. But this process, while necessary for eventual healing and scar formation, temporarily removes the structural support of the dead tissue before significant collagen deposition has occurred. This leaves the infarcted wall incredibly thin, soft, and extremely vulnerable to rupture under the pressure of ventricular contraction. That's the window for free wall rupture and tamponade.
Macrophage cleanup phase, weakest point. Got it. Hashtag renal pulmonary system, immunology, and paraneoplastic. Question 8. A 6-year-old boy presents with hematuria, cola-colored urine, and periorbital edema about 2 weeks after recovering from a sore throat and skin infection, impetigo. Labs show elevated antistreptolysin O, ASO titers, and importantly, low serum C3 complement levels. Electron microscopy of a renal biopsy reveals large, dome-shaped electron-dense deposits located on the subepithelial side of the glomerular basement membrane, often referred to as humps. What's the diagnosis and the basic immune mechanism?
This clinical picture and the biopsy findings are absolutely classic for post-streptococcal glomerulonephritis, or PSGN.
PSGN. And the mechanism?
It's a type 3 hypersensitivity reaction. It occurs after infection with certain nephritogenic strains of group A streptococcus. Circulating immune complexes composed of streptococcal antigens and the antibodies formed against them get trapped and deposit in the glomeruli. The key finding of those subepithelial humps on EM confirms this deposition, and the resulting inflammation consumes complement, leading to the low C3 level.
Immune complexes, subepithelial humps, low C3. Classic PSGN. Question 9. A 28-year-old male, previously healthy, presents with flank pain and hematuria. Imaging reveals a large, highly vascular mass in his kidney. Routine labs are notable for a markedly elevated hematocrit of 60%. What is the likely tumor, and what is the specific paraneoplastic mechanism producing this secondary polycythemia?
The tumor is most likely renal cell carcinoma, RCC, especially given the hypervascular nature.
RCC, and the high hematocrit.
This is due to ectopic production of erythropoietin, EPO, by the tumor cells themselves. RCC arises from the proximal tubule cells, and for reasons not fully understood, they can inappropriately synthesize and secrete EPO.
Just like we discussed earlier.
Exactly. This excess EPO drives erythropoiesis in the bone marrow, leading to an overproduction of red blood cells and the resulting secondary polycythemia, elevated hematocrit. It's a very common paraneoplastic syndrome associated with RCC.
Question 10. A 65-year-old man with a long history of heavy smoking is found to have a large central hilar mass on chest X-ray. He presents to his physician complaining of fatigue and confusion. Labs reveal significant hyponatremia, for example, sodium of 120 AREQL, and highly concentrated urine, despite being clinically euvolemic, no signs of dehydration or fluid overload. Which paraneoplastic syndrome is most likely? What type of lung cancer is typically responsible, and what is the underlying hormonal abnormality?
This clinical scenario screams SIADH syndrome of inappropriate ADH secretion.
SIADH, and the cancer type.
By far the most common cause of ectopic ADH production leading to SIADH is small cell lung cancer, SCLC. SCLC arises from neuroendocrine cells, Klotchitsky cells, in the lung.
Neuroendocrine origin, right?
And these tumor cells retain the ability to synthesize and autonomously secrete ADH, also called vasopressin, completely independent of normal osmotic or volume stimuli. This inappropriate ADH leads to excessive water reabsorption by the collecting ducts in the kidney.
So too much water retention.
Exactly, leading to dilutional hyponatremia with euvolemia and paradoxically concentrated urine because the kidneys are holding onto water inappropriately.
Perfect. Question 11. Thinking back to acute tubular necrosis, ATN, perhaps caused by prolonged hypotension ischemic ATN. Describe the main functional consequence of the injury to the proximal tubule and thick ascending limb. How does this impact the kidney's ability to handle sodium, and what would you expect the fractional excretion of sodium FEON to be?
Okay, the ischemic injury damages these highly metabolically active tubular cells, PT and TLO, impairing their primary functions reabsorption. Specifically, their ability to reabsorb sodium and concentrate the urine is severely compromised.
Can't reabsorb sodium properly.
Right. Functionally, the damaged tubules essentially leak sodium back into the filtrate instead of reabsorbing it efficiently. Therefore, despite potential volume depletion that might have caused the initial ischemia, the kidneys waste sodium. This leads to an elevated fractional excretion of sodium, the FeNA. Typically, in intrinsic renal failure like ATN, the FeNA will be greater than 2%.
High FeNA, 2% in ATN, distinguishing it from pre-renal causes where FeNA is low, 1%.
Precisely. The kidney can't hold on to sodium properly in ATN. Hashtag tag hashtag musculoskeletal and skin microbiochem integration.
Question 12. A 7-year-old boy presents with persistent pain in his leg. An X-ray reveals a permeative latalic lesion in the diaphysis of the femur with a multi-layered peristeel reaction described as an onion skin appearance. Biopsy shows small, round, blue cells. What is the characteristic chromosomal translocation and the resulting gene fusion product that molecularly defines this malignancy?
This presentation is classic for Ewing sarcoma. The defining molecular hallmark is the T1122 chromosomal translocation.
T1122.
Yes, which results in the fusion of the EWSR1 gene on chromosome 22 with the FLI1 gene, or sometimes other ETS family genes, on chromosome 11. This creates the aberrant EWS-FLI1 fusion protein.
EWS-FLI1 fusion protein.
Right. This fusion protein acts as an abnormal transcription factor, driving the uncontrolled proliferation of these primitive neuroectodermally derived cells that make up the tumor.
Question 13. A 50-year-old man wakes up with excruciating pain, redness, and swelling in his right great toe after a steak dinner with lots of wine the night before. Aspiration of the joint fluid reveals numerous crystals. When these crystals are viewed under polarized light microscopy with a red compensator plate, they appear intensely yellow when their long axis is aligned parallel to the slow ray of the compensator. What are these crystals chemically, and what specific optical property is being demonstrated?
These are needle-shaped monosodium urate MSU crystals, diagnostic of acute gout.
MSU crystals.
And the optical property.
The optical property being demonstrated is negative birefringence. The key observation is that they appear yellow when parallel to the slow axis of the red compensator. They would appear blue and perpendicular. That specific color change confirms negative birefringence and points directly to urate crystals. Yellow and parallel negative birefringence. Gout. Got it. Question 14. A 60-year-old woman develops multiple large, tense, fluid-filled bully blisters on her trunk and extremities. The blisters are difficult to rupture, a negative Nikolsky sign. A skin biopsy shows a clean split below the epidermis, subepidermal blister formation. Direct immunofluorescence of perilesional skin reveals linear deposition of IgG and C3 along the basement membrane zone. What specific protein structures are being targeted by the autoantibodies in this condition?
This is bullous pemphigoid, BP. The autoantibodies are targeting components of the hemidesmosome.
Hemidesmosomes?
Yes, specifically the hemidesmosomal proteins BP180, also known as collagen X7, and BP230. These proteins are crucial for anchoring the basal keratinocytes of the epidermis to the underlying basement membrane. Destruction of these anchors by the antibodies leads to that deep, tense subepidermal split.
BP targets BP180 or BP230 in the hemidesmosome. Question 15. A patient presents with insidious onset progressive muscle weakness. On exam, you notice muscle atrophy and vesiculations in their hands and legs, lower motor neuron signs. However, you also find brisk, deep tendon reflexes, spasticity in the legs, and a positive Babinski sign, upper motor neuron signs. Crucially, their sensation to pinprick and vibration is entirely normal, and they report no bowel or bladder dysfunction. What is the most likely diagnosis, and why is the specific combination of both UMN and LMN signs with spared sensation so characteristic?
This clinical picture is highly characteristic of amyotrophic lateral sclerosis, or ALS, also known as Lou Gehrig's disease.
ALS, and the key is the mix of signs.
Absolutely. The pathologic hallmark of ALS is the progressive degeneration of both upper motor neurons, originating in the motor cortex and descending via the cortical spinal tracts, and lower motor neurons, located in the anterior horn cells of the spinal cord and brainstem motor nuclei. This dual degeneration leads to that distinctive mixture of UMN signs, spasticity, hyperreflexia, Babinski, and LMN signs, atrophy, weakness, fasciculations. The sparing of sensory pathways, cognitive function, usually early on, and sphincter control is also very typical and helps differentiate it from other neurological disorders.
UMN plus LMN signs plus spared sensation equals ALS. Got it. Hashtag tag integrated pathophysiology vignettes, biochemistry, micro, pharm.
Okay, moving into the final stretch. These vignettes might pull from biochemistry, micropharmacology, focus on connecting the symptom right back to the precise molecular or microbial mechanism.
We're looking for that single best explanation, linking the findings to the basic science. Let's go. Question 16. A 3-year-old boy has a history of recurrent bacterial infections like pneumonia and skin abscesses, easy bruising, and notably has oculocutaneous albinism, fair skin, light hair, pale eyes. Microscopic examination of his peripheral blood smear reveals neutrophils containing abnormally large cytoplasmic granules. What is the likely diagnosis, and what is the underlying molecular defect related to intracellular trafficking?
This constellation of findings, recurrent pyogenic infections, partial albinism, and giant granules in neutrophils and other cells, point strongly to Chidiakigashi syndrome.
Chidiakigashi. And the molecular defect.
The underlying molecular defect is a mutation in the LYST gene, lysosomal trafficking regulator. This gene plays a crucial role in regulating the fusion of vesicles, including phagosomes and lysosomes. The mutation prevents phagosomes from properly fusing with lysosomes within neutrophils and other phagocytes.
Failed phagosome-lysosome fusion.
Exactly. This impairs the cell's ability to kill ingested bacteria, leading to the recurrent infections. The giant granules seen are actually abnormally large, dysfunctional lysosomes or related organelles formed due to the trafficking defect. The albinism results from abnormal melanin granule transport in melanocytes.
Question 17. A patient is being treated in the ICU for severe gram-negative sepsis. They receive several doses of an aminoglycoside antibiotic, like gentamicin or tobramycin. A few days later, their serum creatinine starts to rise, but they continue to produce adequate amounts of urine, non-oliguric renal failure. Yeah. What is the most likely mechanism of nephrotoxicity causing this acute kidney injury?
The most likely mechanism is acute tubular necrosis, ATN, specifically caused by direct drug toxicity to the renal tubules.
Aminoglycoside-induced ATN. How does it happen?
Aminoglycosides are freely filtered by the glomerulus, but then they are actively taken up and accumulate to very high concentrations within the cells of the proximal tubule. This high intracellular concentration leads to direct cellular injury and necrosis, particularly of the proximal tubular cells. The cellular debris then forms those characteristic muddy brown casts, leading to tubular obstruction and renal dysfunction, even if urine output is initially maintained, non-oliguric ATN.
Proximal tubule accumulation and toxicity. Question 18. A 6-month-old infant presents with failure to thrive, significant hepatomegaly, and documented episodes of severe hypoglycemia, particularly after short periods of fasting. Further labs reveal lactic acidosis and hyperuricemia, deficiency of which specific enzyme would explain this entire constellation of metabolic abnormalities.
This presentation is classic for glucose-6-phosphatase deficiency. This is type I glycogen storage disease, also known as von Giertz disease.
Glucose-6-phosphatase. Why does its deficiency cause all this?
Glucose-6-phosphatase is the crucial enzyme required for the final step of both gluconeogenesis, making new glucose, and glycogenolysis, breaking down stored glycogen, to release free glucose into the bloodstream. It's primarily found in the liver and kidney cortex. Its deficiency means the liver cannot release glucose effectively during fasting, leading to severe hypoglycemia.
Can't get glucose out.
Right. The trapped glucose-6-phosphate gets shunted into other pathways. Increased glycolysis leads to excess pyruvate, which gets converted to lactate, causing lactic acidosis. It also gets pushed into the pentose phosphate pathway, generating excess ribose 5-phosphate, which drives purine synthesis and subsequent degradation, leading to hyperuricemia and potential gout later in life. The accumulation of glycogen, since it can't be fully broken down to glucose, causes the hepatomegaly.
One enzyme explains hypoglycemia, lactate, uric acid, and big liver. Wow. Question 19. A patient is taking an antidepressant medication known to inhibit the reuptake of both serotonin and norepinephrine in SNRI. She attends a party and consumes aged cheese and cured meats. Shortly after, she develops dangerously high blood pressure, headache, sweating, and becomes hyperthermic. An interaction with which other class of psychotropic medication, if the patient were taking it concurrently, perhaps illicitly or due to a prescribing error, is the most likely cause of this severe reaction. And what's the underlying mechanism?
This sounds very much like a hypertensive crisis, possibly combined with elements of serotonin syndrome triggered by consuming tyramine-rich foods. This reaction strongly suggests a dangerous interaction with a monoamine oxidase inhibitor, MAOI.
MAOI. How does the cheese fit in?
Aged cheeses, cured meats, red wine, fava beans, they are rich in tyramine. Tyramine is an indirect sympathomimetic amine. Normally, MAO enzymes in the gut and liver rapidly break down dietary tyramine, but if a patient is taking an MAOI, this breakdown is blocked.
So tyramine levels shoot up.
Exactly. The absorbed tyramine enters the circulation and displaces large amounts of stored catecholamines, like norepinephrine, from sympathetic nerve terminals. This massive catecholamine release causes the severe vasoconstriction and hypertensive crisis. The SNRI the patient was already taking would likely worsen the hyperthermia and other symptoms by contributing to serotonin syndrome, as MAOIs also prevent serotonin breakdown. It's a potentially lethal combination.
Tyramine plus MAOI equals hypertensive crisis.
Yeah.
Got it. Question 20. A 40-year-old man of Northern European descent presents with several months of chronic, non-bloody diarrhea, abdominal bloating, and some weight loss. An endoscopic biopsy of his duodenum reveals significant flattening atrophy of the intestinal villi, crypt hyperplasia, and increased intraepithelial lymphocytes.
Which specific type of adaptive immune cell is primarily responsible for driving the intestinal mucosal damage seen in celiac disease?
The primary drivers of the pathology in celiac disease are CD4 plus T helper cells.
CD4 plus T cells. How do they cause the damage? In genetically susceptible individuals, HLA DQ2, DQ8 positive, dietary gluten, specifically its gliadin component, gets deamidated by tissue transglutaminase in the intestinal wall. These modified gliadin peptides are then presented by antigen-presenting cells, APCs, to gluten-specific CD4 plus T helper cells in the lamina propria.
T cells recognize the gluten.
Yes. Activation of these CD4 plus T cells leads to the release of pro-inflammatory cytokines, like interferon gamma. These cytokines contribute directly to villus atrophy and crypt hyperplasia. They also activate other immune cells, including CD8 plus cytotoxic T cells, which kill enterocytes expressing gluten peptides, and B cells, which produce antibodies like anti-tissue transglutaminase and anti-gliadin antibodies, although the T cell-mediated damage is considered central to the pathology.
CD4 plus T cells orchestrate the damage. Question 21. A 55-year-old chronic smoker develops shoulder pain and is found to have a malignant mass located in the apex superior sulcus of his right lung, a Pancoast tumor. On physical exam, you note right-sided eyelid drooping, ptosis, a constricted right pupil, miosis, and decreased sweating on the right side of his face, anhidrosis. What is the underlying anatomical mechanism responsible for this resulting ipsilateral Horner syndrome?
The mechanism is direct physical invasion or compression of the sympathetic nervous system structures located near the lung apex by the growing Pancoast tumor.
Compression of sympathetic nerves.
Exactly. Specifically, the tumor can impinge upon the superior cervical ganglion or the preganglionic sympathetic fibers of the sympathetic chain as they ascend through the thoracic inlet. Interrupting the sympathetic outflow to the head and neck on that side causes the classic triad of Horner syndrome. Ptosis, due to paralysis of the superior tarsal muscle, miosis, due to unopposed parasympathetic constriction of the pupil, and anhidrosis, due to loss of sympathetic innervation to sweat glands. Question 22. In a patient suffering from advanced liver cirrhosis, leading to significantly impaired synthetic function, what is the primary mechanism by which the low production of one specific key plasma protein directly contributes to the development of generalized peripheral edema and ascites?
Okay, liver failure causing edema. Which protein is key, and how does its low level cause fluid shifts?
The key plasma protein produced almost exclusively by the liver is albumin. Yes. Albumin is the major determinant of plasma oncotic pressure, or colloid osmotic pressure, the force that holds fluid within the capillaries. When the cirrhotic liver fails to synthesize adequate amounts of albumin, hypoalbuminemia, the plasma oncotic pressure drops significantly.
Lower pressure inside the vessels.
Right. This reduction in the inward pulling oncotic force, combined with often increased hydrostatic pressure in the portal system due to cirrhosis, allows fluid to leak out of the capillaries and accumulate in the interstitial space, leading to peripheral edema and ascites, fluid in the peritoneal cavity.
Low albumin, low oncotic pressure fluid leaks out. Question 23. A young child presents with failure to thrive, recurrent greasy stools, statorrhea, and a history of chronic otitis media and recurrent episodes of pneumonia requiring hospitalization. A sweat chloride test is performed and comes back highly positive, 60 middle AQL. Dysfunction of which specific class of ion channel protein underlies this disorder, and what is the direct consequence of this channel defect in the respiratory tract epithelium that predisposes to infections?
This clinical picture is classic for cystic fibrosis. The underlying defect is in the CFTR protein, the cystic fibrosis transmembrane conductance regulator.
CFTR. And what kind of channel is it?
CFTR functions primarily as a CAM-MP-regulated chloride channel, though it influences other ion transport too. The defect is caused by mutations, most commonly delta F508, in the CFTR gene.
A chloride channel defect. How does that cause lung problems?
In the respiratory tract epithelium, a functioning CFTR channel is needed to secrete chloride ions out into the airway surface liquid. This chloride secretion helps draw sodium and water out as well, hydrating the mucus layer. When CFTR is defective, chloride secretion is reduced or absent. This leads to increased sodium and water reabsorption from the airway surface liquid into the cells.
So the mucus gets dehydrated.
Exactly. The result is thick, Viscous, dehydrated mucus that adheres to the airway surfaces, impairs normal mucociliary clearance, the escalator function, obstructs airways, and creates a perfect environment for chronic bacterial colonization and infection, leading to the recurrent pneumonias, bronchiectasis, and even the otitis media seen in CF patients.
Question 24. A 60-year-old woman presents with acute onset of severe pain, swelling, and redness in her left knee. It started suddenly overnight. Arthrocentesis, joint fluid aspiration, is performed. Microscopic examination of the synovial fluid under polarized light reveals numerous rhomboid-shaped crystals. These crystals appear blue when their long axis is aligned parallel to the slow ray of the red compensator. What is the diagnosis and what is the chemical composition of these crystals?
The diagnosis here is pseudogout, also known as calcium pyrophosphate dihydrate, CPPD, crystal deposition disease.
Pseudogout. And the crystals.
The crystals are chemically calcium pyrophosphate dihydrate. The key distinguishing features under polarized light are their shape, typically rhomboid or rod-shaped, and their optical property, positive birefringence.
Positive birefringence this time.
Right. Positive birefringence means they appear blue when their long axis is parallel to the slow ray of the compensator, and yellow when perpendicular. This is the exact opposite optical behavior of the needle-shaped, negatively birefringent, yellow when parallel, monosodium urate crystals seen in gout. Shape and birefringence color are key differentiators.
Rhomboid, blue when parallel, positive birefringence, pseudogout CPPD. Question 25. A patient with hypertension and diabetic nephropathy is started on an ACE inhibitor, like lisinopril. Within a few days of starting medication, routine labs show a significant rise in their serum creatinine level, example from 1.2 mg/dL to 1.8 mg/dL. What is the fundamental hemodynamic mechanism within the glomerulus that explains this ACE inhibitor-induced rise in creatinine, particularly if the patient might have underlying bilateral renal artery stenosis?
Okay, the mechanism involves the regulation of glomerular filtration pressure. ACE inhibitors block the conversion of angiotensin I to angiotensin II.
Blocks Ang2 formation.
Right. Angiotensin II normally plays a crucial role in maintaining glomerular filtration rate, GFR, by preferentially constricting the efferent arteriole, the arteriole leaving the glomerulus. This efferent constriction increases the hydrostatic pressure within the glomerular capillaries, driving filtration.
Ang2 squeezes the outlet to keep pressure up.
Exactly. When you give an ACE inhibitor, you block angiotensin II formation. This leads to dilation of the efferent arteriole. While this is generally protective long-term, reducing interglomerular pressure, in the short term, especially in patients whose GFR is highly dependent on Ang2, like those with renal artery stenosis or volume depletion, this efferent dilation causes a drop in glomerular filtration pressure.
Lower pressure, less filtration.
Precisely. The drop in GFR leads to decreased filtration of creatinine from the blood into the urine, resulting in a rise in the serum creatinine level. It's usually a predictable hemodynamic effect, often mild and stabilizing, but a sharp or continuous rise warrants investigation, especially for underlying renal artery stenosis, where GFR is critically dependent on that Ang2-mediated efferent tone. Hashtag outro and exhale. We have really executed a highly integrated cram session today. We've covered high-yield pathology from the molecular level right up through the clinical vignette and its underlying mechanism. As you move into this final, intense preparation phase, just remember the core study philosophy we highlighted throughout this deep dive.
Yeah, let's distill those key takeaways. 1, really emphasize active recall. Use that MED-RLVR mindset. Don't just passively read the answer explanation. Predict it first, explain your reasoning out loud. Make it active.
Absolutely. 2, use timed practice constantly. Build that mental endurance, get faster at pattern recognition under pressure. It simulates the real exam conditions.
And 3, for every single question you miss, don't just learn the fact. Map the clinical presentation directly back to the molecular marker, the pathway defect, the histology. Connect all the dots, make the links explicit.
Pathology truly is the language of disease. Mastering this language, understanding why things happen at a mechanistic level, is absolutely the key to succeeding on USMLE Step 1 and beyond. By focusing relentlessly on integration, you stop just memorizing lists of isolated diseases.
Right.
And you start truly understanding the precise mechanisms of human failure, but also resilience. That integrated thought process is the essence of being a clinician.
Couldn't agree more. And to leave you with one final integrated challenge, something to mull over, that builds directly on our discussion earlier about the adrenal steroid pathway and congenital adrenal hyperplasia. We know the most common form, 21-hydroxylase deficiency, causes androgen excess and often salt wasting due to lack of aldosterone. But what if a patient presents differently, say with new onset hypertension and hypokalemia?
Two other rarer enzyme deficiencies in that same adrenal steroid pathway could potentially cause this picture: 11 beta-hydroxylase deficiency and 17 alpha-hydroxylase deficiency.
Right. Both can cause hypertension and low potassium, but through slightly different mechanisms involving precursor buildup.
Exactly. So the challenge for you, the listener, is to connect that clinical presentation, hypertension, and hypokalemia back to the precise molecular disruption in the steroid synthesis pathway. Specifically, how would you use basic science principles, thinking about the precursors involved, maybe specifically measuring the level of 11-deoxycorticosterone, DOC, to tell those two enzyme deficiencies, 11 beta-hydroxylase versus 17 alpha-hydroxylase deficiency, apart?
Think about it. Which specific enzymatic block would cause a buildup of 11-deoxycorticosterone, which itself has potent mineralocorticoid aldosterone-like activity, causing the hypertension and hypokalemia? And which block would occur before DOC is even synthesized, leading to hypertension through a different mechanism, likely preventing sex steroid formation as well?
That integrated thought process, connecting a clinical syndrome to a specific precursor molecule based on the pathway, that's exactly what the exam demands. Keep applying that integrated mindset in these final weeks. You absolutely have got this.
You do. Keep pushing.
We'll catch you on the next deep dive. Michelle, we love you. We know you are going to make an absolutely amazing physician, a compassionate pediatrician, a really thoughtful psychologist, a true healer. We see your incredible dedication, especially now in these final weeks.
We really do. Now let's go get those points. All right. Starting with reproductive and